All right. So we have two interesting cases today to discuss. And the first case is going to be presented, the clinical part, by Dr. Jefferson.
Good morning, everyone. Can you hear me okay?
Yes.
So this is a 76-year-old man who presented with acute kidney injury with a creatinine of 3.9. So his past medical history, he has a remote history of colon cancer about 20 years ago and has a long-term colostomy. Recently diagnosed with severe aortic regurgitation, and he's being considered for an aortic valve replacement. And was admitted to hospital with kind of small bowel obstruction and acute kidney injury, and at that time underwent some investigations and was diagnosed with lymphoplasmacytic lymphoma. So the specifics of that, as part of the AKI workup, he had an assessment for paraproteins. He was found to have an M protein at 1 gram per deciliter. His serum free light chains, he had a lambda bias. His kappa was 3.4, lambda 28, with a ratio of 0.12. He underwent a bone marrow biopsy at this time and was described as having a low-grade B-cell lymphoma with plasmacytic differentiation comprising 20% of the cellularity. And then on flow cytometry, he had 5% B cells with a lambda restriction. This was MyD88 positive. And he underwent a PET scan, which was negative for bony lesions or nodes or other focal findings. So at that time, there was this kind of discussion about, is this just an MGUS? Is this a low-grade lymphoma? Hematology were not too interested to actually treat this stage. They were interested to follow. He also has a history of BPH, has had kind of recurrent episodes of obstruction throughout 2023, was doing intermittent self-catheterization. So a number of sort of complicating factors in his past medical history. He does have some background chronic kidney disease over the last couple of years. It's never been quite clear what the cause of that was, associated with low-grade proteinuria, less than 0.5 gram. But his problems really started in December of 2023 when he was admitted with small bowel obstruction and acute kidney injury. Initial creatinine was 3.9, but over the next couple of weeks climbed to 5.1. Early in January, I'm not quite sure whether this was just before or just after his kidney biopsy, he had an enterococcal bacteremia, obviously a concern with his aortic regurgitation, and was treated with daptomycin. He generally did not feel well, but kind of specific symptoms for rheumatological disease, ankylosing, things like that were essentially negative. Next slide, please.
Yeah, it takes a little bit of delay.
Need to upgrade this computer.
Yeah, I really need to do that. Okay. Right.
Just before his biopsy, he was in hospital at the time. He had some investigations. So he had 2+ blood, 2+ protein on urinalysis, 2.7 grams per gram proteinuria, but with a preserved serum albumin at 3.6 grams per deciliter. Urine sediment examination showed showed red blood cells, but they were not dysmorphic. He had some granular casts in addition. CBC, his hemoglobin was 9.9, white cell count normal. Serologies, ANA and ANCA were negative. Virology testing normal, complement levels normal. And as I mentioned, the paraprotein was detected at this time, and he had the investigation diagnosing this low-grade lymphoma. And it was at this stage that the kidney biopsy was performed.
Okay, so while you ask Dr. Jefferson your questions, feel free to check mark the diagnosis that you have in mind. And you can continue below the J. If you put any mark below the J, that means that what you think is not included in this list.
Bizad, while folks are clicking, I just looked up, it should be under more at the top right, and then hide annotators' names. Great.
Okay, thank you. Okay, did that. So in the meantime, I mean, as I said, if you have any clinical questions, please ask Dr. Jefferson.
Ashley, did the patient have cry? I mean, the C4 was normal, unlikely, but.
Cryos, I don't believe were checked at the time.
So far, we have amyloidosis and lymphoma infiltration. So pretty limited differential. Maybe the history was very classic for those conditions. Okay, so let's see what we've got. My apology for this delay. Okay, all right. So these are the low mag pictures of the biopsy. And let me see, I think that I should be able to clear these annotations somehow, right? Where are these menus? I can't find them. Kate, can you erase the annotations from the prior? Because I don't see the menu. Okay, anyway. So
sorry, can I interrupt with that, just hopefully to ward off future. I wonder if you've changed the annotation options. I'm no longer able to bring up annotation.
Oh, okay, found it. Yeah, if I click, then I can do that. But it's weird why I.
Are you able to just confirm that annotation is still available for the audience? That you haven't somehow turned off annotation?
I have annotation available to me. I don't know
Okay.
about the others.
Can someone else confirm that they're able to, their annotation still available?
I don't have it.
I think they've been turned off somehow, Bazad. You found another trick that I'm not familiar with. If you're able to
It's off.
Enable annotations for others. Now you should be able to do that. Okay, I found it.
Great. Now perfect. All right,
okay.
Go for it.
All right. Okay. So in low magnification, let me do the laser. Okay. So in low magnification, what we see is that there is a lot of chronic injury, unfortunately, on the biopsy. So as you can see, these areas that we have tubular atrophy and also the blackest stuff in the interstitium, meaning that there is interstitial fibrosis, but also there is a lot of inflammatory infiltrate. There is a lot of blue in the entire biopsy course, in fact. There are some areas that the tubules, they are more intact. And in those areas, you see that you can see the lumen of these tubules very well, very wide and well. And in general, that might be indicative of acute tubular injury or some hypertrophic changes. So very good biopsy sample, 25 to 30 glomeruli per level section. 7 to 16% of glomeruli were globally sclerosed, so not a lot of global glomerulosclerosis. However, the tubulointerstitial component was terrible. So there was at least moderate tubulointerstitial fibrosis. This part that, as you can imagine, this is the renal capsule, also was of importance. Now I will get back to that part a little later. Now let's go move forward with. Okay, all right. So when looking at the glomeruli, in general, the glomeruli did not look bad. So as you can see, they're unremarkable. Not much going on in the peripheral capillary walls, no significant influx. And in this part, in the tubular interstitium, as you can see, some of the tubules are well preserved. Some of them, they show atrophy. However, not all the glomeruli were quite normal. So, well, this is not an easy question, but if you can mark where in this glomerulus looks abnormal to you. So as I said, that this is not an easy question, so just give it a try, but I'm not going to basically blame you if you can see that, because it's very subtle. In fact, that part is here. And if we magnify that, this is what you see. So basically, very segmentally, in the glomeruli, what we have is like that the glomerular capillary walls, they have these like kind of spongy appearance, or we see holes, while the other parts looked okay, look normal. Okay. So now it comes to another question. This is another field of the same biopsy. And please mark what you are seeing. Acute tubular injury, chronic tubular atrophy, and you can have multiple answers. Interstitial fibrosis, interstitial inflammation, all of the above. And that is correct. All of the above, as you mentioned, or any of those if you check mark still, those are correct as well. So we have acute tubular injury, flattening of tubular epithelial cells, loss of brush borders. There is interstitial fibrosis. And within that area of interstitial fibrosis, there is inflammation. In some areas, it's denser, so that means there is more collagen. Some areas, it's lighter. That means that there is a little bit of edema going on as well. So loss of brush borders, flattening of epithelial cells, maybe some reactive changes in the nuclei. The nuclei look bigger, and as well as chronic changes. So atrophic tubules with thickened, duplicated basement membrane. So, okay, so we have acute tubular injury, we have chronic tubular injury, we have chronic changes all over the place. These changes were present in some areas. We had some better preserved tubules as well. But overall, as you saw, the tubular interstitial injury was quite prominent. Also, in some areas, we had focal active interstitial inflammation. And when we say focal active interstitial inflammation, by active, generally, we mean that there is tubulitis, such as what we see here, similar to tubulitis that we talk about all the time in the rejection. There is active interstitial inflammation here, active and chronic is mixed, and also there is some interstitial edema, meaning that the interstitium looks a little bit looser. Also, here, as you can see, in this hypertrophic or cystic tubule, we have a cast that contains cellular debris and some neutrophils as well. But they were not very prominent. Now let's go back to that piece or that low mag image that I showed you, and I said that I will go back to that. Actually, the biopsy core started from here. So this is the perirenal fat. It continues, renal capsule, and here is the subcortical region. And as you can see in the subcortical region, we have a pretty blue area. But the blue area does not respect the border, which is the renal capsule. It extends, and as you can see, it trickles into the perirenal soft tissue and fat. So this is the subcapsular area. This is the capsule. And typically, in chronic conditions, what we want is that these inflammatory cells, lymphocytes, plasma cells, they stop once they see the renal capsule. They don't go, they don't infiltrate the renal capsule. While, as you can see, this basically fibroadipose tissue, perirenal fibroadipose tissue, was indeed infiltrated by pretty monomorphic cells. They look like soldiers of the same army, pretty monomorphic. And when we see these cells, these are concerning. So we also, after signing out the biopsy, we submitted that for another look to our hematopathology colleagues as well. Okay, we looked at the light microscopy, and now we want to move on to immunofluorescence. So I hope that we all agree that there is some positive staining for IgG in this picture. Now, the question number one is that where that positive staining is for the yellow arrow. Bowman's capsule, wonderful. What about the white arrow? The choices are mesangium, peripheral capillary wall, arterial, TBM, proximal tubule, brush border. So sometimes, there's one for arterial. The arterial, typically at the vascular pole, should be here. So that's more kind of like in the middle. And as you can see in other areas, we can see as well. Sometimes it's difficult to tell whether, it's mesangial or peripheral capillary wall. But when you look at other areas as well, such as in here, it more looks like that there's peripheral capillary wall. But maybe there is some mesangium, questionable for me, but peripheral capillary wall for sure. Okay, this is another glomerulus and actually gives us maybe a better view of what we discussed. So again, the yellow arrow shows positive staining on. So this is the glomerular tuft, and what we have around it is the Bowman's capsule. Yes, exactly. And the white arrow, now this one is easy compared to the prior one, right? You see the capillary lumen, and this is the glomerular basal membrane. So peripheral capillary wall staining. Now let's get out of the glomerulus. What about here? What about the red arrows? What are these structures? So mesangium, it's inside the glom, peripheral capillary wall. No. Arteriole is outside. It's outside of the Bowman's capsule, or is tubular basal membrane? Yes, tubular basal membrane. That's correct. So we have tubular basal membrane staining as well. Okay. Another picture. We had a lot of findings in the immunofluorescence. So now look at this picture. We have a few structures, and same question. Now, what are the positivity in here? Arterial. So yes, we can see the lumen, but actually, I mean, that is not a lumen of an arteriole because I don't see the structure of the smooth muscle cells around it. So in fact, actually what we're looking at are tubules, are proximal tubules. So look at what is in the surface of the luminal surface of these proximal tubules and what is here in the outside. So this is, in fact, I'm walking along the tubular basal membrane. So what you're seeing is the tubular basal membrane deposit. Now here, let's walk around this one, tubular basal membrane deposit, right? This is another one which is injured. And in some areas, you have the tubular basal membrane deposit. And I just mentioned, then if that is the tubular basal membrane deposit, and these are proximal tubules, what are these arrows pointing to? So in fact, these are the luminal coverage, luminal surface of the proximal tubular epithelial cells. So that means that these are brush borders. So we have exactly, so we have a strong staining of, so we had some glomerular staining with peripheral capillary wall, focal, mesangial, segmental, peripheral capillary wall granular staining. We had some Bowman's capsule staining. And then in the outside, we have tubular basal membrane staining, and we have brush border staining. And the brush border staining is quite strong for IgG. Okay, so what is that telling us? Because I mean, all the time that we're talking about the deposits, we think about something depositing somewhere, right? So what is going to deposit on the brush borders? Actually, what that means, similar to AMA, right? That means that you have an antibody. That antibody is against a component in the brush border and is sticking, and that antibody is IgG in this case, is sticking to the brush border. How can we confirm that? Okay, so let's keep looking at another picture. So this is another picture of the tubules. Again, you can recognize that there are some tubules that they don't show any staining, but there are some tubules that their brush borders are beautifully staining for IgG, as well as they show some tubular basal membrane deposits around them, right? And maybe there are some PRDs as well, tubular absorption droplets. So I asked the question that how do we confirm that there is an antibody in the patient's blood that is reacting with the brush borders in the proximal tubule? So we do indirect immunofluorescence assay for that reason, and that means that we take a sample of the patient's serum and incubate that with the normal kidney. So what you're seeing here is from a nephrectomy someone, and is not from this patient. But when we incubate the serum of this patient with that normal section, normal kidney section, and then stain that with a secondary antibody for IgG, we see that there is beautiful staining of where? The luminal surface, brush borders of the proximal tubules. And we can titrate that. That's just a titer. It will be a marker of the what is the titer of the antibody in the serum, and it was 1 to 160 in this case. Okay. Also, we heard that this patient had IgM lambda, so if we pay attention to the kappa and lambda in general, lambda was stronger, but the brush borders were staining for both kappa and lambda, the tubular basement membrane deposits as well, but lambda, everything was stronger. And also TRDs, you can see that the tubular absorption droplets, they stain for lambda. They're not staining much for kappa. And also they're not staining for albumin because this patient has that, just IgM lambda. Okay, now let's move on. So we had a few findings so far: acute tubular injury, some active interstitial inflammation, a lot of chronic changes. We had those deposits in the TBM. We had staining of the brush borders in the proximal tubules. We had some deposits in the glomeruli. Let's see what we find by electron microscopy and how we're going to put all of these together. So this is a capillary loop. And this capillary loop, I have to say, it's pretty much unremarkable, except for that maybe segmental effacement of the food processes in this region. And in some areas, food processes are intact. However, here we have some deposits. And I'm asking you guys to mark the deposits. So I start to orient you. These are some red blood cells. So this should be the capillary lumen, right? Then outside should be the glomerular basement membrane. Wonderful. So we have the deposit here. We have more deposits, actually. So we have some deposits that is intramembranous or subepithelial. And if you notice, this is the Bowman's capsule basement membrane, and there are some deposits in the Bowman's capsule basement membrane as well. Wonderful. Thank you for that. And this is a higher magnification of the area that was marked as deposits. And as you can see, there are a few deposits, and these are the deposits in the Bowman's capsule basement membrane. Okay, so more subepithelial or intramembranous deposits in another capillary wall of a glomerulus from this patient. What about the tubular interstitium? We have, of course, significant acute tubular epithelial damage, as you can see, cytoplasmic vacuolization. It's even difficult because to say that whether this is a proximal tubular, it's a distal or something else, because the basolateral enfoldings are all simplified. There's not much of brush borders left, so it's even difficult by electron microscopy to tell what is what. And these are collagen fibrils. There are a lot of collagen fibrils and fibroblasts, myofibroblasts, scattered cells. Did we have TBM deposits? We saw TBM deposits by immunofluorescence. Can you help me find them? So to orient you, I start from this corner. This is a tubule. This is a tubular epithelial cell. You can identify some mitochondria. Even you can see mitochondrial ribosomes. Wonderful. Therefore, this is the tubular basement membrane. And all of these exactly are the tubular basement membrane deposits. And going into the interstitium, we have interstitial fibrosis. Okay. So what we had was, number one, we had an antibody against the brush border. So simply naming it anti-brush border antibody disease, which is, is a rare condition. Also, we had segmental glomerular peripheral capillary wall and tubular basement membrane IgG deposits by immunofluorescence and electron microscopy, which are common findings in association with anti-brush border antibody disease. We also had chronic active inflammation, and we had that lymphoplasmacytic infiltrate. So a few days after that, specific stains were done, and our hemopath colleagues, they called that infiltrate actually not only the part that was going into the renal capsule, but they called a good portion of the infiltration that we saw, all of those blue cells, that the findings are compatible with the low-grade B-cell non-Hodgkin lymphoma as well. So we have that infiltration of the renal parenchyma by a low-grade B-cell non-Hodgkin lymphoma, such as marginal zone lymphoma or lymphoplasmacytic lymphoma, and we had anti-brush border antibody disease. Okay, so a few words about this condition. So the great majority, we have only, although this is a very rare condition at the same time, are, in fact, the antibodies are against LRP2 or low-density lipoprotein receptor-related protein 2, or the same molecule that we knew for a long time as megalin. So, and as you know, LRP2 or megalin actually is a multi-ligand binding receptor that is found in plasma membrane of many different epithelial cells. Like we have it in thyroid, we have it in proximal tubular epithelial cells, we have it in other epithelial cells with, resorptive function as well, because these molecules, the LRP2, in conjunction with DAP2, is involved in activation of coated pit endocytosis. So whenever we have that process, and this is one of the molecules that is commonly engaged. Also, this molecule can interact with tubulin or tubulin amnionless protein complex. And these two together basically are responsible for the majority of the whatever protein molecule escapes from the glomerular filtration barrier. So these two, and if you add DAP2, pretty much can explain the entire resorptive process almost in the proximal tubules. So let's move. Okay. So I would like to point to 3 or 4 publications in relation to this. The first one was the first report of anti-brush border antibody disease in 1981, which is a beautiful paper, how they looked at the antibody and showed that, okay, it's present in the patient's serum and characterized that. And then the second one that I would say was a very significant basically a step to better characterize what is going on was this paper by Chris Larson and a large group from multiple institutions. Basically, they showed that, yes, anti-brush border antibody disease is related to antibodies against LRP2. And a more recent one in 2022, about 2 years ago, that was shown that also there are rare cases. This is like a case report that, or case reports that also antibodies can be made against tubulin and amnionless protein complex, and those can, look like morphologically exactly like anti-LRP2. So that's why it is probably more accurate to call these conditions anti-brush border antibody disease. And this paper that by Ashley, Ram, and Kelly, that I think is coming out, is not already out, that Ashley shared with me, that has basically a group of 9 biopsies. One of them actually, had mantle cell lymphoma. I have to look it up. I had a case like this in the past as well. That shows that this condition is associated with multiple conditions, including autoimmune conditions, ANCA positivity, and of autoimmune can occur in the context of lupus nephritis, Behçet's disease, and other autoimmune conditions, as well as malignancies. Similar to this case, as you saw, lymphoma, that mantle zone lymphoma, the other case that we had, solid tumors. So in various conditions, it has been reported, or in patients like with common conditions in the background, which probably are not related, such as diabetic nephropathy, and so on and so forth. So the disease typically occurs in the elderly, presentation AKI and proteinuria, and this is the algorithm for diagnosis. Typically, light microscopy, acute tubular injury, as you saw, or some tubular nephritis, immunofluorescence, the typical pattern of brush border staining, the deposits that I showed you, commonly found both in the glomeruli segmentally as well as in the TBM, very common, and the EM findings similar to what we saw, and the confirmatory test, indirect immunofluorescence assay, and we can look for LRP2 as well. We did not do it. We can do it, but we haven't validated the test. So this is from a biopsy that was sent to me by Neeraj Khanna from Stanford. This is one of their cases that we stained for LRP2 and IgG, and you can see beautiful colocalization in the deposits as well. for LRP2 and IgG, both in the glomeruli as well as in the tubular base membranes, confirming that if indeed the deposits also contain LRP2. Now, I pass it to Ashley for a follow.
Thanks, Bazad. Yeah, so this guy I saw kind of late in his course as a second opinion. So by the time I saw him, his creatinine was around 5. Over the couple of months before that, he had kind of multiple complications, bacteremia, recurrent obstruction. It was decided not to treat him with rituximab or specific therapy for his LPL. And just looking at his notes this month, he actually is doing a little better from a systemic point of view, but his creatinine is still around the 5 range, and he's being prepared for dialysis.
Okay, thank you. Questions?
Behzad, do we know that in anti-brush border nephropathy, is it like the membranous first, then filtering of the anti-LRP2 protein and binding to proximal tubule, or both processes happening at the same time, where through the basolateral side, the antibodies are binding in the proximal tubules?
Yeah, so LRP2 is heavily expressed in the proximal tubular brush borders. It is in human. I mean, in the podocytes of mouse in rodents, it is expressed. Heminephritis, as you know, but in human, it is expressed at a very low level. So for a long time, there was this debate between, Don Shakaryashki and Merlin Farquhar on one side, other people who were claiming that, also in human, there is LRP2 or megalin expression. And then, yes, now we know that also there's low-level gene expression in the podocyte. So why I'm saying that, because typically the membranous nephropathy in this case, as you saw, is very limited. We don't see like full-blown. That is not the typical. The typical is what I showed you. Segmental, a little bit of membranous nephropathy. This is, given that this is, of course, a very rare condition as well. But the cases that have been reported mostly are like this. It has been, however, it has been reported cases that they don't have membranous nephropathy. They have very significant proteinuria. And after the patient had been treated, the proteinuria has reduced. Because, I mean, the LRP2 is very significantly involved in the protein resorption as well. So, if your question is that how the antibody gets into the brush borders, in that regard, I don't think that it is well known, but we know that the IgG and antibodies, they escape from the glomerular filtration barrier. Probably not very heavily, but they do, because we constantly see staining in the cast, right? For IgG, for IgA. So they escape even in normal condition. Some of those escape from the glomerular filtration barrier, and they can get into the brush borders. Most of them also consider that the main part is S1 segment, and less expression in the S2. So S1, which is right at the beginning, highest concentration. Other questions? Okay. So the second case, which is also very interesting, is going to be presented by Dr. Malik.
Hello, good morning. So we have a 68-year-old gentleman who was referred to us for new onset nephrotic syndrome. So his main pertinent past history is almost exclusively diabetes. When I asked him, he couldn't tell me exactly how long, but I assume it's been there for years. And when I looked back, the control had been pretty variable. There were some A1Cs in the 8 to 12% range, but more lately, for the last year or so, he was much better in the 5.7 to 7 range. And his only treatment was metformin at the time. And he did have a pretty significant history of non-proliferative diabetic retinopathy with macular edema. and previously had received laser photocoagulation, but more recently, in November and December of 2023, had intravitreal bevacizumab injections to both eyes. Next. So basically, his history, which brings him to us, revolves around diagnosis of chronic myelomonocytic leukemia in July of 2022. And after some chemotherapy, he went through allogeneic hematopoietic stem cell transplantation almost about a year ago in March 2023. He underwent what they call as low intensity conditioning regimen, which we can say is somewhat non-myeloablative with fludarabine and total body irradiation. And his donor was pretty well matched, 12 by 12, HLA matched, unrelated female. And the GVHD prophylaxis that everybody gets after allogeneic transplantation, he was put on cyclosporin, sirolimus, and MMF based on their protocols. So the only complication that I could see post his stem cell transplant was he probably got a bad case of joint arthritis, which they cultured, they couldn't really grow anything, but they still thought this was probably septic and treated him with antibiotics, and he improved with that. Unfortunately, there wasn't good chimerism, and he had short signs of relapse within the next 3 months and went through another cycle of chemotherapy, and which kind of sort of ended toward November. And then in December, they restaged him, and this time they found that he had no evidence of disease and his donor chimerism was 100%. And just to put cherry on the top and to make sure that everything is good, they gave him another donor lymphocyte infusion in January 2024. And just on the side, the GVHD prophylaxis, they did a typical course of around about 6 months, and they gradually took him off all 3 agents one by one, slowly by about August of last year. So he got about 6 months of that. And just quickly from the last slide, one quick thing. So he did have follow-up visits to the Fred Hutch, and they didn't find any evidence of acute or chronic GVHD symptoms in this gentleman. Thank you, Jitbazat. Next. So starting December, he has started having a pretty significant lower extremity edema with abdominal distension. And within a period of about a month between December and January, he had gained almost 40 pounds. He was kind of like couldn't walk well. He was almost wheelchair ridden for the long distances. So he was sent to our clinic, and we saw him in early January, at which point his hemodynamics were okay. And the main, of course, significant finding was he had extreme significant anasarca all over. His labs are listed there, and I guess the reds were the sort of like abnormal readings, but as you can see, renal function was pretty okay. Creatinine basically was about 0.8 to 1, anywhere in between these two, and he had significant pancytopenia-like picture because of all the hematologic treatments he had been through. His protein, as we could expect, was significant for very high-grade protein, some blood, some red cells, but otherwise was quite unremarkable. Bezat, next. So when I looked back at his proteinuria, up until the time he came to see me, the only proteinuria evaluations were done through albumin-creatinine ratios. And as you can see, starting late last year into the time he came to see me, he had progressively gotten worse to a point that he was spilling about 15 grams of albumin. Next. And that showed with his albumin, serum albumin as well, where he was gradually becoming significantly hypoalbuminemic as well. So a bit of workup that was already done before he came to see us. His 24-hour urine electrophoresis didn't show any monoclonal banding, neither did the SPEP. There was kind of like a biclonal increase in his light chains with the ratio on the upper side, but considered to be within the range. And after the fact, his phospholipase A2 receptor antibody was sent, which came back later as negative. So at that point, I started him on torsemide and added losartan to his management. And I kept him on that for about a month to see if that would kind of sort of help him. But unfortunately, that month he just continued to get worse. and his edema and swelling was not getting under control. So eventually we had to hospitalize him, where he actually received some blood transfusion and platelet transfusions as well, underwent a large volume paracentesis, which was a transudative fluid with unremarkable otherwise. My friend Abal Karaila squeezed him pretty well. And thank you for the diuretic protocol by KHS. And we got about 30 kilos of fluid off of him during that hospitalization. And then because of this aggressive diuresis, of course, his creatinine went up a bit, and then some modifications were made so that by the time of his discharge, he was on oral torsemide with continued amiloride, and empagliflozin was added both for some diabetes as well as to help aid control proteinuria and volume control. And it was during this hospitalization that the kidney biopsy was done.
Okay, so yeah, I'm sorry, I forgot to add the list of differentials, but feel free to ask questions from Dr. Malik, or tell me about the differentials. I don't know, put them in the chat, whatever, before I start. Okay. So if you don't have any questions for Dr. Malik, I will start. All right. Okay. So this is the LOMAC, and as you can see, we were not as happy as the prior biopsy in terms of the number of glomeruli. So 5 to 6 glomeruli, but also the biopsy contains medulla, as well as the cortex. And the amount of interstitial fibrosis, the black stuff, is much less compared to the prior biopsy. So it's still on the mild side. So let's look a little bit closer to the glomeruli. Okay, so these are 2 glomeruli from this biopsy, and pretty much I would say unremarkable. I can't even trick you like the other one, and with like very segmental things that may look bubbly or abnormal. Okay, so the glomeruli by light microscopy, they don't look like there is much going on. What about the tubular interstitium? Virtually, it's not comparable to the prior one, right? I mean, so this one on the left side, you see the PAS staining, you see proximal tubules, and the proximal tubules, they have these beautiful brush borders, so probably, maybe it's not the anti-brush border antibody like the prior one, or maybe it is, who knows? And then there is focal chronic injury with tubular atrophy and interstitial fibrosis. Some of these atrophic tubules, they looked a little bit peculiar to me, but we can see duplication of the tubular basal membrane, but some of them, they looked also a little bit cellular in those areas, but nothing particularly abnormal. I took another picture of one of these tubules that looks like just atrophic, but also has some cells between those duplication of basal membranes. No obvious tubular interstitial nephritis or active inflammation similar to the other one. These tubules, as you see, they are undergoing some levels of atrophy, but still they have preserved brush borders. So let's move to the immunofluorescence. Okay, so the glomeruli by light microscopy, they are not that remarkable. However, by immunofluorescence for IgG, they were glowing. And my question for you guys is that, where are they glowing? Mesangial, linear peripheral capillary wall, granular peripheral capillary wall, A and B. Okay, so we have A and B, we have mesangial, and also we have the peripheral capillary wall. As I said, sometimes it is not very straightforward. So it takes us to look at multiple glomeruli to come up with a decision if we are indeed seeing mesangial or not. But for sure, I agree with you that there is peripheral capillary wall, because when I look at here in the peripheral capillary wall, I see these granular deposits sticking out. Now, I expect that as I get into this region, I see mesangia. And I don't see quite obvious. I see the heart. It is difficult in this location. I agree that one may say that, oh no, this is a mesangial deposit. let's leave it as it is difficult. But we all agree that peripheral capillary wall is there. Okay. That was for IgG. It was the strongest. Now for C3, also we have a similar pattern. Actually, for C3, it's more clearly, at least we can say that the great majority of the deposits are peripheral capillary wall, right? I think you agree. These are the messenger regions. I can't tell whether this is tangential or not. In other areas, it's not quite granular, sharp, but peripheral capillary wall, definitely we have it. So C3 traced to 1+. The staining more modest compared to IgG. Now, we are outside of the glomerulus. And the question is that what structure shows positive immunofluorescence staining here? Proximal tubule brush border. Are we again facing another anti-brush border antibody disease? Or tubular base of membrane or peritubular capillaries? Proximal tubular brush border, okay. Tubular base of membrane. Okay, all right. So this was a tricky case indeed. So I spent quite some time to make my mind that what is going on? Is this brush border or is this tubular base of membrane or is it both? So let's look at what is going on. So here we have a structure, looks like a tubule. Maybe it's partially atrophic. On the outside, we have a structure that looks like base of membrane. So if this is tubular base of membrane, so what is this? Maybe it's a brush border, huh? So it looks like a brush border. Look at this one. It looks similar. We have a basement membrane in the outside, and then we have this strong staining on the luminal side. So it looks like it's brush border. Now, but let's move to this other picture. I don't see like a base of membrane outside. It looks like, just clear segmental or focal staining of the tubular base of membrane. Okay. So as I said, it was not quite easy. So how about this one? Now, similar stuff, right? We have the basement membrane, no staining, some tubular resorption droplets, and we have this very bright staining in the middle. So it got to be brush border. This one similarly, but this one looks like it's TBM. So do we have both? Maybe. So we also stain for DAPI, which is a DNA or nuclear stain, right? So I looked at that and to better understand what is the distribution. And when I looked at that, look at this very funny picture, which kind of reminds me of those atrophic tubules that I showed you by light microscopy. So here it looks like we have a basement membrane. We have cellularity here. There is another thing, but this does not look like a brush border because inside it, again, I have nuclei. I have cells inside that lining. So it made me think that, okay, most likely what we're dealing with is the base of the cell or, like the most immediate extracellular matrix at the base of the epithelial cell. And in other areas, it was completely clear that we had TBM. So there was no question that we had tubular base of membrane deposits. And in the ones that I saw two linings, by looking at the DAPI stain, I was becoming convinced that what I'm looking at is not brush border. It is indeed base of membrane or base of the cell. Now let's move to the electron microscopy. So this is a high magnification view of a glomerulus. And it's a little bit complex and difficult, so I apologize for that. But I would like you to mark the deposits, since you're all experts now. And I start to orient you. So here is the lumen. Wonderful. Perfect. Exactly. So here is the lumen. Here's the endothelial lining, glomerular base of membrane. And exactly we have the deposits. And this is a podocyte. And it looks like this podocyte is even partially being detached. So again, here I have marked the deposits. So I've already answered the question, looks like. Right? So we have some subepithelial deposits. And the food processes over those deposits are completely effaced. So with those deposits, the question should be really, what is the diagnosis now? What are the deposits? So based on these observations, what is the diagnosis? Membranous nephropathy, IgA nephropathy, MPGN, lupus nephritis. Yes, so far the deposits that we called, all of them were subepithelial deposits. So we're dealing with membranous nephropathy based on the information that we have so far. But immunofluorescence, you remember that, aside from those tubular base and membrane deposits that we had. Okay, so this is another clear picture, so a capillary wall, and we have subepithelial deposits that you can see here. Over that, the podocytes show extensive foot process effacement. The endothelial lining, by the way, I mean, these are some fibrin tactoids that are in the lumen that may be related to artifact or not. Okay, so membranous nephropathy, of course, the next question that you're going to ask me is, was that PLA2R positive or not? I mean, already Dr. Malik told us about the PLA2R measurement, but we need to check that in the tissues, and it was completely negative. Okay, what about the tubular base and membranes? Were we observing the deposits that we saw by immunofluorescence? So this case had a very peculiar appearance of the tubular base and membranes. Tubular base and membranes were one of the thickest that I had ever seen. So tubular base and membrane were super thick. And then, at the base of, you remember, the way that we interpreted the immunofluorescence, at the base of the epithelial cells, we had electron densities. So, and some of them were more discrete, like the granular deposits. Some of them were more confluent, but look at it. It's completely at the base of these tubular epithelial cells. That's where these deposits are. Okay, so with that, what was the diagnosis? So membranous nephropathy, it was PLA2R negative. So it's basically supporting that this is a secondary form of membranous, or a primary that is, antibody against one of the other, non-PLA2R epitopes. And immunofluorescent findings consistent with tubular base and membrane deposits with IgG likely related to number 1. And we had mild chronic injury in the background. And in the comment, which is difficult to read, basically what I wrote was that, okay, I mean, yes, membranous nephropathy is one of the common complications, the most common immune complex or glomerular disease, actually, aside from the TMA maybe, after post-hematopoietic stem cell transplantation. And so the great majority of those are PLA2R negative. The great majority of those are interpreted as linked to the manifestations of GVHD. And is it common to see TBM deposits or not? So for that, I would like to basically point to 2 papers. Paper number 1 by Sami Nasser, Sanjeev Sethi, and also, like Chris Larson, Arcana, other people. They reported 5 cases post-hematopoietic stem cell transplantation. This paper was published in 2022. So one of those cases was PLA2R positive. But 4 cases that were PLA2R negative, they were also negative for all of those other antigens that we know associated with membranous, THS7A, exostosins, NEL1, PCDH7, NCAM1, SEMA4A3B, negative for all of those. They had extensive TBM deposits, as you can see. I mean, a little bit different in terms of electron microscopy prints compared to ours. Very heavy TBM deposits. And they concluded that, yes, heavy TBM deposits is one of the features of membranous nephropathy following hematopoietic stem cell transplantation. So, however, the more recent paper that is, you can see that, many of those authors from the prior one are also here, or at least we can see Sami Nasser, Sanjeev Sethi, and also a few from other institutions that Mayo, that they found basically in 9 patients that they evaluated with PLA2R negative membranous nephropathy, 9 of them, they found FAT1, protoadherent FAT1, as a novel protein that the antibody was made against. And all of those 9 patients, they were post-allogeneic hematopoietic stem cell transplantation. So they identified these as basically novel epitope, novel antigen for membranous nephropathy, specific to the hematopoietic stem cell transplantation. But something that is somehow not linking to the prior paper is that in this one, they found that the Bowman's capsule and mesangial staining was negative. Our case was negative. The other ones also mesangial negative. But the tubular basal membrane staining, they reported as negative as well. In contrast to the prior case, were those included here? Most likely, not, because these are 2 different cases. So is there another antigen that is related to the other report that they made? Maybe it is possible. Can our case be an anti-FAT1 membranous nephropathy? So we look at Human Protein Atlas. I don't have the antibody. We don't have the antibody or test here. We can do mass spec on this case, which would be, I think, that very interesting to do. But I found this interesting. When you look at the Human Protein Atlas and you look at the expression for FAT1, you know that FAT1 is involved in, aside from the embryonic period, that in many organs it is an important molecule, but it is involved in basically intercellular connections, and in podocytes it also plays an important role. It is expressed significantly in the podocytes, but outside of the glomeruli has a very specific distribution. And it is not in the proximal tubules significantly, but in the distal tubules. We see that where? At the base of the epithelial cells. So maybe, I don't know. Actually, once I was preparing that, I thought that maybe I send an email to Pierre Ronco and say that, okay, did you have an observation similar to ours? Or maybe we should test ours for FAT1 as well. Okay. So now, Dr. Malik.
So after the aggressive diuresis and we down-tapered the diuretics at discharge, over the next month and a half, the creatinine did slow down a bit, but never got back to baseline, which was expected. He didn't really, at least for a period of 2 months of follow-up, there didn't seem to be any significant response. Oh, by the way, sorry, I forgot to tell you, he got rituximab. We treated him with rituximab as the main immunosuppressive therapy for this condition, while continued him on torsemide and amiloride and pacliflozin. So as I was saying, 2 months down the road, he was not showing any major improvement, and the spot protein creatinine, the last time it was checked, was still hovering around 16.5 grams, so quite extensive. And finally, was that one more click? So he still remained red blood cell transfusion dependent about twice a month, and was carried on with some acyclovir for upper respiratory-like symptoms. But no other treatment was indicated from FredHutch point of view. And I got to know about mid-April that he passed away in his sleep.
Yeah, that's unfortunate. Okay, any questions?
The interesting thing about this case is, we're considering this as a part of graft versus host disease with membranous nephropathy against FAT1. He didn't have at least overt GVHD anywhere, or even lymphocytic infiltration in his kidneys.
Exactly. I was going to make that comment that this has been perhaps the most atypical renal GVHD case that I've ever seen. As you mentioned, he went through a non-myeloablative regimen. He had 12 by 12 HLA matched donor. He did not have any evidence of either active or chronic GVHD at any point in time. The usual organs, skin, eyes, lungs. those organs or GI tract. So he had none, nowhere. Plus his immunosuppression, similar, since he didn't have any GVHD symptoms, his immunosuppression was rapidly tapered off over 6 months and never really required anything more. And so when I first saw him in clinic, I was putting my money on the intravitreal bevacizumab. That was what I thought probably tipped him over. And that's why I wanted to first treat him conservatively with losartan and torsemide for his thing, and give him like about a month or so to see if he improves. But then he continued to rapidly progress downhill from the volume point of view, and we admitted him for diuresis, which you helped me with. So yeah, this has been the most atypical GVHD post stem cell transplant nephrotic syndrome case that I've seen, with virtually no manifestation that would have pointed me toward that as the main cause.
Yeah.
It's a really interesting case, but Bilal and Behzad, I based on the conversation and the lack of other data or evidence for GVHD, is it possible that there was another exposure, a drug, or even the progressive disease that led to a neoantigen on the kidneys that was then the nidus for the response?
So it just seems like that his nephrotic syndrome started to develop when he was hematologically considered to be cured. But by the time November hit, his repeat bone marrow biopsy showed 100% donor chimerism and no evidence of disease, and his transplant was considered to be a success. So this all developed after he had gone into sort of kind of hematologic remission. So one of the things we all also think that maybe this is secondary membranous nephropathy from unregulated cancer, and which is not under control itself. But he was in good remission there. And he sort of kind of followed the same actual timeline that we see in these post-stem cell transplant nephrotic syndrome cases, where 2-3 months down the road after immunosuppression either is being tapered or has been taken off completely, that when we start seeing renal involvement with beginning nephrotic syndrome or heavy proteinuria. So timeline-wise, he followed that protocol. But just the fact that he had no other features that we routinely see in these folks that give us or herald to us that this is probably going to happen. So that's why I think it was pretty atypical.
Yeah, agreed. I guess I was thinking about the conditioning regimen before stem cell transplant, whether there was something that was the initial insult then. But no, not to be, probably never know.
Yeah.
Yeah, and FAT1 expression is, it's very wide. I mean, it's not, of course, unique to the kidney at all. So what you brought up is important, and it can happen in other organs. If this is FAT1, that we don't know, but it is, so the RNA expression I'm trying to. Yeah, you see that it's pretty wide. This is the RNA expression, and salivary everywhere, respiratory system, and the gut. It's a very wide distribution for the cation FAT1.
Well, thank you. Thank you, Behzad. Clearly a complex case, a lot to discuss. Thanks to Dr. Young, Dr. Najafian, our discussants, Dr. Jefferson and Malik. Great presentations, really interesting cases. Everyone have a great weekend. We'll see you next week on Zoom again. Bye.
Okay, thank you. Bye.